And hello, everyone. Welcome back to class. So we're in week number 2 now and looking at chapter 2. And it was nice getting to know you, a little bit of your backgrounds. And we've got a small class this year, and that's going to be great because it's going to allow us opportunities to, again, really get to know each other, especially in the context of our forums. And so throughout the term, there'll be times where I'll ask you to post on something. And then the second part of that will be for you to post on fellow classmates' threads. And in the past, when I've had 17 or 20 people in the class, it's hard to read through all of them, but you'll be able to read and learn from each other because you're required to post on two other individuals. And also, too, I will post and have comments, questions. I'll try to pose other ideas and, of course, highlight successes and things that you've done really, really well. So, for this week, we're looking at measuring health and disease. So, we're looking at measures of frequency, and this is in chapter 2 of your textbook. Now, this week we have both a discussion and a homework assignment, and you can see the due dates there of September 14th. Also, there are two screencasts. You're listening to lecture 2 right now, and this is part 1. There'll be 2 parts. What I try to do is limit the length of each screencast to approximately 20 minutes. Once you're done with one screencast, move on to the next one, or however you're able to fit them in with your schedule. There's also a supplemental screencast, and this screencast is illustrating what I'm looking for when it comes to your presentation that you're going to do later on in the term. You're going to record yourself doing a screencast, and it's going to be similar to what a platform presentation would be like. So we want to keep things to 10 minutes. There are a few papers this week which, again, illustrate aspects of measuring health and disease, and you'll need those to complete your homework assignment. There are also poster examples, and as I mentioned previously last week, you're also going to be completing a poster assignment. A poster is a great way in a scientific conference to present your research. So both the platform and the poster are very common, and we're going to practice those. That's why they're integrated into this class. Your homework assignment is 10 points. Just upload it into Canvas, and there is, with each question, a notation of how much each problem is worth. Okay, let's talk about the reading assignments from last week. And again, all of the papers that I've put into Canvas, these are not studies for you to become experts in the content. Rather, there are things I want you to get out from them. Seeing examples of how the paper is written, seeing examples how things are laid out, see examples of tables and figures, and start to appreciate the different statistical analyses that are performed with different study designs. So Brock et al. Is a prevalence paper. And prevalence is one of the things we're going to be exploring this week. Within the abstract, as you know, you're going to get information about the purpose of the study and the background why the study needs to be done. There's going to be some basic information on the methods, a presentation of the results, and then a little bit possibly related to statistical analyses, but not consistently. And then, of course, finally, a conclusion. And so how can you, in 250 to 300 words, when creating an abstract, get across all of the information that is pertinent from an epidemiologic study? And the reason I say that, and something for you to think about, is there is a lot of data presented in epidemiologic studies. This is where tables and figures become very valuable. And so seeing examples of those, I think, are key. If you're reading just the text only, it gets really dense. It gets hard to wade through all of that. And so a great table, a great figure is going to bring to life that information in such a way that is more consumable to most readers. The other study was Yang et al., and this is an interesting one, and it forces us to think about, does the findings from an epidemiologic study mean that we need to focus on that thing, or does that thing represent something else? So what do I mean by that, as I kind of, am kind of clunky as I make that explanation there? Well, in this study here, they looked at push-up exercise capacity and the risk of cardiovascular events among active adult men. And they found that higher baseline push-up capacity is associated with a lower incidence of cardiovascular disease events. And so that's really kind of interesting, because you might think about a push-up as maybe being a measure of strength. Now, there's probably really both a strength and a muscular endurance capacity component to it, because one is doing repeated repetitions for as long as they're able to go. When we think about cardiovascular disease, we think about, though, like, hey, what's one's aerobic capacity? What's one's health of their heart, and how the heart is positively impacted by things like running and fast walking and bicycling. Well, in this particular study, again, they found that the higher baseline push-up capacity is associated with a lower incidence of cardiovascular disease. And so, is it that somebody who does a lot of push-ups, does that mean that that is the thing that makes their heart healthier and helps to reduce the risk of cardiovascular disease? Or is the push-up test kind of a marker for general fitness of an individual? And that's what I meant before about, is it the thing, or is it a thing representing something else? And in this case, probably it is representing total body fitness. And so the push-up test is something that can be quickly done, inexpensive, relatively fast to perform, and a much easier to do test than like a VO2 max test. But that's kind of the fun stuff with epidemiology, is looking for those relationships, looking for those associations. So the purpose of this week is to gain an understanding of measures of disease or injury frequency, and these being things like prevalence and incidence. So key messages from the chapter: the measure of health and disease is fundamental to the practice of epidemiology. A variety of measures are used to characterize the overall health of populations. Population health status is not fully measured in many parts of the world, and this lack of information poses a major challenge for epidemiologists. So, whenever we start with an epidemiologic study, we're interested in a disease state, an injury state, or some sort of health outcome. And it's always great when we can utilize something that is an accepted term. Well, here's an example. What is health? Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. That's coming from the World Health Organization. That's a big a big definition there, and it wouldn't be something that you would utilize that particular definition in a study. But how do we unpack that now? Well, again, if you're doing epidemiologic research, we want to define specifically what is of interest health wise. So if you are looking at mental health, are you looking at depression, anxiety? Are you looking at bipolar disorder, schizophrenia, addiction? If you're looking at physical health, are you looking at different physiologic markers that we can measure, like lipid levels, right? A1C, or are we looking at things like the push-up test, a measure of general strength and muscular endurance capacity? So again, it's important that you define what is the health thing you're looking at and what specifically is the disease or injury of interest. Now, in some epidemiologic studies, things can be very simple. For example, is a disease absent or is it present? And so an epidemiologist would then categorize subjects based upon the presence or lack thereof of a disease. More than likely, you're going to want to develop a comprehensive definition. And this is referred to often as the operational definition for that injury or illness. This will then help you categorize subjects into the sick or injured category or the not sick or not injured category. So here's an example of an operational definition from the research that I've done looking at collegiate level athletes. And this is not a definition that I came up with, but it's one that I utilized, or borrowed's not the right word, but adopted something that my dissertation chair used. His name is Mitch Rao, and he's a physical therapist and a researcher out of San Diego State University. He was also a former faculty member with Rocky Mountain University. The operational definition of an injury was any muscle, joint, or bone problem / injury of the low back or the lower extremity that occurred during practice or competition via a non-contact mechanism that required the athlete to be removed from that day's event or to miss a subsequent practice or competition. So it's very specific there and includes injury mechanism as well as an objective measure of time loss. So again, the strengths of my particular operational definition, that time loss component versus a non-time loss component. Because if something is a non-time loss component or injury, is it really an injury? You know, when somebody comes into the athletic training clinic at the college and they say, hey, my calf is hurt. Okay, did you miss practice? No. Are you going to miss practice? No. Is that an injury? Well, I was saying it was not, because there was not the consequence of lost time from sport. I also wanted to make sure that I did not include contact-related injuries within my definition. Why is that? Well, a lot of times when you do epidemiologic research, you're trying to see, can you potentially intervene? So my hope was to find a consistent pattern of injury risk based upon preseason functional test scores, like how far they could jump or their agility drill test. And if those people were at risk, could we intervene with targeted exercise programs to improve those scores, thus reduce the risk of injury? When it comes to a contact injury, basically if you hit somebody hard enough, they're going to get hurt. And so there's not really a way to reduce the risk of contact-related injuries, at least not in my opinion. Weaknesses of my particular operational definition. they weren't always specific to medical diagnoses. So now what could be a specific thing? Well, what if you're interested in endurance runners and you wanted to look at low back pain or maybe patellofemoral pain? Those would be specific diagnoses, and that's going to potentially even be a stronger study. Now, as clinicians, we may lack access to certain tools that allow us to optimize our ability to rule in or rule out a particular diagnosis. For example, look at something like anterior knee pain versus patellar tendinopathy. Both of these things, for those of us that work in these areas, we can understand the difference. But then to highlight people that have pain with either anterior knee pain or patellar tendinopathy, they're having pain in the front of their knee and they might describe it in similar areas. Well, if you're doing an epidemiologic study looking at risk factors associated with patellar tendinopathy, you're going to want to have tools that would help you to rule in or rule out the diagnosis. For example, you would want to have access to diagnostic ultrasound. That's going to be important because that's going to show health changes in the tendon. You wouldn't want to rely just on palpation because palpation may reveal tenderness with the patellar tendon, but it also may reveal tenderness in other areas in that anterior knee region. Now, several measures of disease frequency are based upon concepts of prevalence and incidence. Now, the layperson may intermix these, but in reality, they're completely separate concepts, and this is important for us to understand. Prevalence helps us to answer what proportion of a group of people has a condition. Incidence helps us to know at what rate do new cases arise in a defined population as time passes. Now, who's our population? Our population are the people who are susceptible to the disease or the injury. They are the population at risk. And so we want to make sure we choose an appropriate population when doing our study. For example, when doing a study looking at injury risk in high school athletes, you would not include collegiate level athletes. That only makes sense, right? Other examples, you wouldn't include females based upon sex in a study involving the prostate. You wouldn't include non-runners in a study looking at risk factors for running-related injuries, and you wouldn't include males based upon sex in a study looking at cervical cancer. So there are two major classifications, like I said, prevalence and incidence. Prevalence studies are typically cross-sectional in nature. And so you're looking for that fraction or that proportion of a group of people possessing a clinical condition or an outcome at a given point in time. Now, there are two types of prevalence studies. There's point prevalence and period prevalence. Point prevalence is that pure cross-sectional study where you're measuring at a single point in time for each person. Period prevalence is all of the cases that were present at any time during a specific period. So period prevalence is everything that occurs at baseline and everything that occurs over a period of time. Period prevalence is kind of like a transition or a mix between point prevalence and incidence. Now, incidence is the fraction or proportion of a group of people who are initially free of the outcome of interest, like a disease or like an injury, that then go on to develop the condition during the surveillance period, during a period of time after the start of the study. And there's two types of incidence that we'll explore. We're going to explore cumulative incidence and incidence density. Now, this is the last slide, actually I'll do 2 slides here before we end this screencast. Measures of frequency are expressed as proportions. So again, the number of people who experience the event, those are our cases, and they're divided by the number of people in whom the event could have occurred, that being the population. When we look at calculating rates, prevalence and incidence data really become useful to us when they're converted to rates. Again, that rate being the number of cases divided by the corresponding number of people in the population at risk, and it's expressed as cases per 10 to the nth power. So in prevalence studies, more often than not, you're going to see something like 80% of the individuals presented with this at baseline. In incidence studies, we're going to report something like 150 people per 10,000 developed an injury. So it gives you an idea about how many per a sample of people. All right, let's stop there. And when you're ready, move on to part 2.